Hi, Dr. Erin.
Hey Akshatha, how are you
Hi.
doing?
Yeah, yeah, I'm doing well. So thank you for joining even early. Do you want to try sharing the screen?
Okay, I can share my screen
Yeah.
to try it. Wait a minute. I am sharing now and okay. Is there any problem?
No problem. Could you put, yes, perfect.
Okay.
Yeah, it's moving. Okay, nice. Yeah. Looking forward for a wonderful discussion. Yeah.
Yeah,
Hmm.
you're welcome. How was it ID weeks?
ID week was good, but there were too many sessions, so obviously couldn't attend many. So I need to see in the online the recordings I need to check because
Hmm.
like there
Uh,
are too many sessions simultaneously and obviously it's an opportunity to do more of networking as well. So at least the sessions you can get to attend online, but the
hmm.
networking part you cannot do.
Yeah, excellent. And
Mm.
what do you want to say when you compare between ECMID and ID week? Which one is the best in your
Oh,
opinion?
I didn't get to attend the ECMED conference this year. I had my exams exactly clashing with the same around the same time. So
Hmm.
but whatever I could hear from the other faculty who had attended, so ECMED is much, much, much bigger than IDWIC as well.
Hmm.
So IDWIC was like they were saying it was almost half that of the ECMED. So I had attended ESPID. ESPID was much smaller. IDWIC was bigger than that, but whatever I've heard, ECMED was much bigger. And
Hmm.
yeah.
In your routine clinical practice, do you see the children patient also or just adults?
No, we do see children because we don't have many pediatric infectious diseases.
Hmm.
So, like most of the common ones, the pediatricians will handle, but the rare ones, difficult ones, we do get cross consultation. So, yes, we do manage pediatric infectious diseases. And as
Just
a part of
pediatric
our,
or both of them? Pediatric plus adults, right?
yes, yeah. But
Okay.
pediatric is much lesser, but we do still see. And during our training, we have rotation in the pediatric ICUs and the pediatric
Hmm.
neonatal ICUs, etc. Yeah. Mm.
Yes, similar.
Mm. So you're like, how many years is the infectious diseases training, or like is how
So,
is it?
it is my third year.
Okay. So how long? How many years is it overall?
Five. Our
5.
training
Okay.
takes 5 years, right? And between the clinical microbiology,
Mm.
we will specialize as ID and CM
Ah, okay.
title.
So that's a good thing. So here in India, we have like 3 years of the like broad specialty that which can be medicine, micro,
Mhm.
etc. Then we have 3 years. After that is the
Mhm.
infectious disease training. So overall 6 years. So we do have combined training as well, but again that is 6 years.
Mhm.
Nice to meet like the various this one.
Nice to meet you
So,
too.
mhm. So we will just wait for like around 5 minutes past 6. I will introduce you.
Okay.
Then I hope like how do you pronounce Erin? Erin is fine, and how do you pronounce the
Eren,
Iran? Okay.
how
Then
about you, Akshata?
yeah,
Is it
Akshita is fine.
okay?
Yes. Okay. Do I need to tell your surname? Like, if can you tell how to pronounce that?
Öztürk,
Otsuk. Is it
but
fine?
you can say Öztürk.
Oh, okay. Okay. Thank you. Hmm.
We discussed the question in the end of the
Yeah.
discussion. Or
Yes. We'll
or
take
part? Just the
questions at the
part.
end of it. So we will in the comments whatever questions or any queries which they can post it. We'll discuss at the end so that there is no interruption in the flow. Yeah. If you want
Okay.
to ask any questions, you can ask questions in between. They can use the comment section to comment either any like any questions, any answers. If you want any
Okay. Good.
opinions, you can just ask.
Okay.
Yes. Hmm. I'll just come back. I need to arrange few things. YouTube, I need to share. I think we are live on YouTube now.
Mm-hmm.
Yeah, just check. I'll just check few things and come back.
Okay.
We shall wait for another 2 minutes. Let other people join in. So, hello everyone, and welcome to this session on exciting webinar series on atypical infections. So, today we are going to dwell into the fascinating world of anaerobic infections. So atypical infections, this is the series which I have started to discuss about the less discussed infections. So I am sure like anaerobic infection, though most of us we do come across but it is not often discussed as well. So this is the inaugural talk and we'll be exploring three crucial topics to shed some light on the more unusual yet significant infection we encounter in the clinical practice. So first and foremost, we have Dr. Erin. Uh, Dr. Erin Ossert is a senior resident in infectious diseases and clinical microbiology at Ankara University, Faculty of Medicine. He is a member of executive committee on specialty training at Turkish Medical Association, and he has more than 10 presentation in national and international conference. And he is also a presenter of the top-rated poster in ECMED 2024 with his area of interest being antimicrobial resistant infections, atypical microorganisms, HIV, brucella, and hepatitis. Today we have with him to discuss on iatrogenic botulism, a condition that we may not think about and but it has critical implication for the patient safety. So without any further ado, I invite Dr. Aaron to deliver his talk. Over to you, Aaron.
Hi, how are you?
Yeah, I'm fine. Yes. Looking forward for this. Uh, could you share your screen?
Okay.
Okay.
Can I start directly?
Yes. You can start your talk.
Okay. Hi, everyone. Good afternoon. And firstly, I would like to thank Dr. Akshatha to invite me. And today I will be presenting a few cases of iatrogenic botulism, which is a rare but significant complication of botulinum injection due to medical interventions and cosmetic purposes. As outlined the presentation plan, I will discuss three cases of iatrogenic botulism and each patient's diagnosis, presentations, treatments, and outcomes. Our first case is 33-year-old woman who presented with blurred vision for 6 days, and she had fatigue and weakness in the arms and legs for 5 days. On the admission, she had dyspnea and chest pain. On the physical examination, all of the vitals were normal, and she had dysphagia and dysphonia. She had decreased muscle strength in her head, arm, and leg, 3/5, and she had coordination issues in hand movements, and laboratory tests were normal. For this The neurologist started pyridostigmine treatment with the preliminary diagnosis of myasthenia gravis, but the expected response wasn't obtained. 1 day later, she had dysphagia, diplopia, ptosis, and dyspnea. When the history was deepened, it was learned that gastric Botox was applied 4 days before the start visual symptoms. And she was treated with botulism antitoxin as 20 milligram of heptavalent type, and her symptoms regressed within 1 day, and the patient was discharged. Our second case is 33-year-old woman. She had no comorbidity, and 10 days ago she had Botox was applied to palms and soles at home due to hyperhidrosis, and she had symptoms or finger numbness, difficulty buttoning, and holding utensils. On the day of admission, she had swallowing and speech difficulties. Her vitals were normal. Physical examination revealed dysphagia and dysphonia. She had weakness in upper extremity muscle, 4/5, and she had coordination issues in hand movements. She was treated with botulism antitoxin as 20 milliliter of heptavalent type. The symptoms regressed within 3 days, and the patient was discharged. Our last case is 45-year-old woman. She had just breast malignancy history, and she had cosmetic Botox around the mouth and forehead. 1 day later, she had nausea, vomiting, numbness around the mouth, dry mouth, and sore throat. On the day of admission, she had limited neck movements. When the history was deepened, she had been receiving Botox regularly for 3 days, but opted for a different clinic this time due to a lower price. On the physical examination, all of the vitals were normal, and she had dysphagia and dysphonia. She had weakness in upper and lower extremity muscle, 3/5, and coordination issues in hand movements. Laboratory tests were normal. Again, she was treated botulism antitoxin of 20 milliliter heptavalent. Symptoms regressed within 3 days, and the patient was discharged. For this patient, public health authorities were alerted about the beauty center where the Botox procedure was performed to prevent further cases. Botulism can classified into several types, like foodborne botulism, infant botulism, wood botulism, and iatrogenic botulism. Foodborne botulism is caused by ingesting toxins, and it is related to consumption of homemade canned foods. It may present as local outbreaks. A second one is infant botulism. When spores are ingested orally by children, the bacteria produce toxins in children's guts. Because of that, the children less than 1 year old should not be fed honey. Third one is wood botulism, subcutaneous or intravenous injection of heroin that is contaminated with spores of Clostridium botulinum is a major risk factor for development of wound botulism. Last one is our topic, iatrogenic botulism is caused by botulinum toxin injection due to medical intervention and cosmetic procedures. As you remember, our cases have iatrogenic botulism as well, gastric Botox, cosmetic procedures, and hyperhidrosis. Let's look at the iatrogenic botulism. The word origin is iatros. It means caused by medical procedure and treatment. We use the botulinum injection due to gastric Botox, hyperhidrosis treatment, cosmetic procedures, bruxism, achalasia, and etc. In differential diagnosis, we can count myasthenia gravis, Guillain-Barré syndrome, stroke, poliomyelitis, aminoglycosides, and encephalitis. In very large doses of aminoglycosides can induce neuromuscular blockade like botulism. Clostridium botulinum is an anaerobic and gram-negative bacillus like Clostridium difficile, Clostridium perfringens, and Clostridium tetani. The Clostridium botulinum produces Clostridium toxin, and the toxin presents botulism. Uh, Please look at the left side of the picture. Normally, when your brain sends a signal to a muscle, it releases acetylcholine at the neuromuscular junction, which tells the muscle to contract. However, in botulism, the toxin blocks the release of acetylcholine. You can look at the side of the right side of the picture. Think of it like cutting off the communication between the nerve and the muscle. The muscle can't contract without this chemical signal, leading to muscle weakness and paralysis. We can see the presentation of iatrogenic botulism. It presents symmetric descending paralysis, and it begins with cranial nerves like diplopia, ptosis, blurred vision, slurred speech, difficulty speaking, and hoarse voice. Additionally, gastrointestinal symptoms can be seen in this botulism, like dry mouth, shortness of breath, but there are no febrile and no mental status change and no acute neuroimaging change in botulism. We can use the diagnostic tests, but they delay our diagnose. Mouse PSA is too hard and it takes a long time. PCR test is just in reference laboratory, not all of the hospitals. And routine laboratory tests don't help. Routine laboratory tests are not helpful in diagnosis because mostly CBC, electrolytes, liver function tests, and urine analysis are normal in botulism. Also, it is too difficult to culture botulism. That's why initial diagnosis is based on clinical symptoms, and treatment should not wait for laboratory confirmation. When we talk about the treatment, we have two types of antitoxin. Heptavalent antitoxin, botulinum antitoxin. It is the main antitoxin and it is derived from horse serum, and it is effective against 7 different types of botulinum toxin from A to G. And the second one is botulism immunoglobulin intravenous. It's called baby BIG. This toxin is specifically used for treating infant botulism, and it is derived from human plasma. These antitoxins work best when given early in the illness, like before 2 days. And when we talk about the reasons of iatrogenic botulism, we know that nowadays Botox became the drug that's treating everything. Like we use it a lot of illness like depression, migraines, erectile dysfunction, back pain, sweaty palms, gastric Botox, and cosmetic purposes as well. And firstly, overdose implementation is a key issue. There is no established standard dose, and excessive amounts of botulinum toxin can lead to unintended paralysis of muscles. Secondly, inappropriate injection techniques also pose a risk. Mapping the injection site can be good strategy to avoid errors. Third, inappropriate toxin selection. Using an unlicensed toxin can increase the adverse effect. It is important to choose the correct product, like Botox and Dysport, based on the patient's needs. Lastly, selecting the wrong patient for botulinum toxin procedures can result in complications, and we must question whether off-label use is appropriate, particularly in cases of hyperhidrosis or extreme aesthetic demands. We have to request these patients, is it really hyperhidrosis or just patient demands like aesthetic? In conclusion, iatrogenic botulism is a rare but serious complication of botulinum toxin injection. Early recognition and treatment with antitoxin are key to prevent severe outcomes. The most important clues are dysphagia, flaccid paralysis, ptosis in patients who has Botox history. we should give antitoxin immediately, and we should follow these patients up in intensive care units because because respiratory failure can be seen in botulism, and medical history and neurological examination are the most important parts of the diagnosis. Botulinum injection practitioners should be trained in careful patient selection and injection techniques. And finally, I would like to thank you, and I want to finish my presentation with two masters of medicine. First person is Hippocrates, and he says that first of all, do no harm, then prevent, finally heal. And second person master is Paracelsus, and his famous dictum is that the dose makes the poison. In way I see it, the differences between poison and drug is dose, and I want to use two famous dictums for iatrogenic botulism. Thank you again, and I would like to improve our collaboration. Thank you.
Thank you, Dr. Erin. It was truly an eye opener. So nowadays we are seeing there is increasing cosmetic surgery, cosmetic usage of botulism toxin, and I think this is one of the places which under is not recognized as an infection and treated mostly wrongly. So if there are, I open the forum for the questions now. If there are any questions, you can post it in the comment section. So, how many cases, are you following up all these cases? What is the prognosis of these patients? I think they recover pretty well after initiating the antitoxin.
All of these patients
Yeah.
are alive.
Okay.
I present just two cases, but in 2023, we had 58 patients, 58 patients diagnosed with iatrogenic botulism, but it was related with gastric buttocks. But in 2024, we see cosmetic procedures and hyperhidrosis related iatrogenic botulism. And in the past, I mean, in 2023, European sites and our country, Turkey, have epidemic for botulism.
Wow, that's great. I think in India, we know none of us are looking for it. Maybe if at all we start looking for it, we may also have more cases. So definitely a thing which needs to be vigilant about. So questions, let me check in my YouTube if there are any questions. Okay, there is a lot of comments about the cases being very interesting and very nicely presented. So
Thank you.
thank you once again, Dr. Erin. So please, I hope you stayed through the presentation. So I hope to continue this collaboration and maybe we'll have more such talks. So it was a wonderful session and then definitely an eye opener. So thank you once again. With that, let's introduce our next speaker. So the next speaker we have Dr. Santanam. He's assistant professor in infectious diseases at Vellamal Hospitals, Madurai. He'll be talking about, he'll be with us to bring the latest updates on Clostridium difficile infection, a common yet challenging infection in the healthcare settings. So over to you, Dr. Santanam. Can you share your screen? Is there any issues? Yeah, you can put it on the slide share, slideshow mode, full screen. Yes.
Okay, ma'am.
Yes. You speak little louder so it's less audible.
Good evening to all. First of all, I'm thanks to Akshatha for initiating.
Your voice is less audible. Can you speak a little louder?
Fine. Good evening to all. First of all, I'm also thanks to Akshatha for initiating and doing so much ID-related activity. And I'm also the part of the team. Let's go. My topic is today Clostridium difficile. What is new? What we are doing also. A 45-year-old male with multiple comorbidities, so OAN, osteoarthritis. When patient have there is some momental perspiration followed by batch repair payment. There is after some time there is vitals are worsening, blood pressure is 150, SpO2 92% is room air, even counts are also changing. It's going like sepsis, even propofol
Dr.
also
Santana.
like
Santana.
yes.
It's all voice. Can you speak little louder? It's not
Okay,
audible.
okay. This was 45-year-old male, multiple comorbidities with hormonal separation. When went for surgery, after surgery, patient's conditions are worsening. Vitals are coming, blood pressure, even SpO2 coming down. Even self, you see, status are 35,000. Procalcitonin is 32. There is signs of sepsis with the X-ray shows left lower lobe consultation. They send for pus culture in pus aspect that shows real E. coli. They started antibiotics with Piptas, Metrogyl, Clostridium also, even Amikacin. Some like the way they suspected viral, like the way they given some Belgium cyclovir, like the way this much antibiotic patient condition still worsening. Anyone want to upgrade? Yeah, because obviously there is patient is sepsis, maybe intraabdominal infection or pneumonia, everything will be there. You want to upgrade antibiotics for this patient. Anyone put it in chart CPT? Start. Anyone want to upgrade antibiotic? Patient conditions are worsening in spite of this much antibiotic. Even Metrogyl, beta-lactam with amikacin, Clostridium also getting patients. Sisters. He is really calling. Okay, let's go. What the you want to upgrade antibiotics, there is always you go with whether Piptas or Meropenem, they have always have anaerobic coverage. Some drugs like Piptas, Meropenem, even like fluoroquinolone, you need to know the spectrum of antibiotics, whether anaerobic coverage is there or not. If anaerobic coverage is there, don't give double anaerobic coverage, by the way, adding Piptas or clindamycin with beta-lactam. Piptas or Meropenem could be avoided. Double anaerobic coverage is not going to give anything better outcome. Then the patient after some time they will land up in our scenario CDAD. We'll go with our, our topic today, Clostridium difficile respiratory diarrhea. We'll see what is epidemiology, pattern, clinical manifestation, diagnosis and treatment. There are different classification is there, anaerobic affects by gram negative and gram positive. There are different sites, different locations also possible with anaerobic, even comments are considered. What is my question is most common risk factor for CDAD, Clostridium difficile associated diarrhea. Anyone put it in chart? Most common risk factor for Clostridium difficile associated diarrhea. Please put it in chart. Okay, let's see. The most common respiratory is either antibiotic. Second one is increased healthcare exposure. Whether the way will be changed, both are all possibilities to most common cause. Either healthcare exposure predominantly or antibiotics. Simple method in healthcare, there is hand hygiene. Another thing is isolation cohort. There will be big problem in our case. Another thing is patients on multiple antibiotics, there will be colonization injuries, then they went to infection aspect. Febrile neutropenia, predominant risk factor for Clostridium difficile diarrhea. Environmental source, the predominant risk factor, either healthcare environment from floor or water or soil, anywhere possible to handle. The antibiotic aspect, they will divide into high risk, moderate risk, low risk. But if you ask me that if you are giving unnecessary antibiotics for long time or multiple antibiotics for long time, patients definitely will end up in CDAD. So theoretical aspect, there is high risk like clindamycin or cephalosporin or chloroquine like that. But if you are giving unnecessarily, the patient definitely will end up in CDAD. Another thing is clinical manifestation. What is the most common symptom for Clostridium difficile associated diarrhea? Please put it your comment. Most common symptoms for Clostridium difficile associated diarrhea. Please. We'll go the how pathogenesis will come. Initially, it will be colonizer. Then, if you are giving long time is persistent in intestine, it will go to infective form Clostridium difficile infection because of toxins. The release symptoms are will come. The predominant symptom is diarrhea, predominantly watery diarrhea. The fever, leukocytosis, and all it will be rare. Even the why we are worrying with Clostridium difficile diarrhea, the itself will cause complications, and also it will increase the risk of other infection like bacterial or fungal. Everything will increasing because of Clostridium difficile associated diarrhea. That's why we are worrying. Any score available for Clostridium difficile associated diarrhea? Please put it in comment. Any score available for Clostridium difficile? These are two scores is there, either JAR score, like Z score. Another thing is Heartless score. Heartless score, another place where you are using like even there will be there is telling
Dr. Santanu, your voice is breaking. Hello.
you. Hello. I'm audible,
Huh.
ma'am.
Yes, yes, you're
Hello.
audible. Yeah, continue, please.
Two scores are there. One thing JAR score, another thing is Atlas score. JAR score and Atlas score. JAR score contains age is predominant mismatch here. More than 60 years, it's considered as 1 point. If you go ICU, most of people more than 60 years around the way. Fever here is 1 point. Fever many times in CDAD won't be there. Albumin, if you are going with ICU, many people will be albumin will be low. You can't tell like this patient in CDAD. Another thing is endoscopic. Endoscopic, predominantly we are not going invasive procedure. That's why it will be very difficult to convince the patient for diagnosis suspect for endoscopy. Another thing is treatment in ICU. If many people will be treatment in ICU, either based on severity, they will put it. That's why it will be supportive score. It's not going to primary diagnosis for based on the score. Here, most common complications are either toxic megacolon or hypotension, even intestinal perforation will be predominant complication. Another aspect already I told, it will increase the risk of bacteremia and fungal infection like candidemia. The diagnosis in the population, what investigation you are doing in diagnosis for Clostridium difficile associated diarrhea in your hospital? What test you are doing? Please put it in comment box. Investigation for CDAD. What you are doing in your practice, in your hospital? Please put it. Okay, let's see. There are different tests there, different tests show different sensitivity and different specificity. If you go toxins alone, it will be low sensitivity. If you go specificity, it will be culture will be predominantly high specificity, but you can't do everywhere in Clostridium difficile diarrhea. If you both, you need to check it whether toxin alone positive or GDH positive. If toxin alone positive, GDH negative, it will be negative symptomatic. Both are positive, you need to consider presumed Clostridium difficile diarrhea. The third thing is suppose toxin negative, still you are suspecting means you go with PCR. PCR coming positive means either Clostridium difficile associated diarrhea or non-toxigenic carrier. Like the way you will decide. Single test alone, it won't give value. First you go GDH for Clostridium difficile, then you go toxin. Still you are suspecting negative patients, you go with PCR. The problem with the testing, if you are doing negative initially coming, still you are suspecting patient persistent diarrhea. If you are repeating again within 7 days, negative doing repeating test will be probability of possibility of infection will be high. Even test positivity also high. If both are all positive means you need to consider as patient is infective, you need to treat. If single test alone positive, it's not going to add any value like the way. Same criteria will follow in syphilis like the way. Single test alone is not going to give any other benefit. These are all things different. These are all multi-factors that affect Clostridium difficile associated diarrhea in test investigation wise for enzyme immunoassay or toxin culture. Everything it will affect based on the steroid or WBC count, even severity also. I told repeating within 7 days is not going to give any benefit in the test. Again, don't test for screening for asymptomatic carrier. Okay, what is treatment? What you are giving in your practice in Clostridium difficile associated diarrhea? What drug you are giving in Clostridium difficile associated diarrhea for symptomatic patients? Please put it in sound box. What drug you are giving? Okay, let's see. If mild to moderate, you will give it pyridoxomycin better than vancomycin. If severe means you will go with vancomycin. If very severe, you will go with combination therapy. If mild infection, pyridoxomycin versus vancomycin, pyridoxomycin better than vancomycin. But problem with pyridoxomycin, the availability in India. Only now few places only we getting pyridoxomycin. Many places it's not able to get it. Vancomycin dose, it will be different for mild to moderate and severe. It will be oral, not IV. Don't confuse here. Simple, but they will many, even I seen 1 or 2 places, they simply giving for vancomycin. IV injection into oral. Don't give like the way. Oral means oral vancomycin give. Here, the 125 mild infection, 125 mg 6 hourly you need to give. Severe infection, you will give 500 mg 6 hourly plus metrogel. Metrogel, there is data they giving oral versus IV. There is no clear-cut data. If you want to give better oral, better than IV, as my practice, I'm doing like that way. Or if you very severe, still not improving, better you will give combination therapy. Another thing is there is suppose ileus or something like ileus or bowel movement diminish, better you will go with enema like vancomycin injection. Better you will give it per rectum you will give. There are different doses also I mentioned here 500 mg in 500 ml uses thirdly. Already I told the pidaxomycin dose will be 200 mg BD for 10 days. There will be different tapering dose also there. I have not mentioned. Initial episode of pulmonary GDA means combination therapy 8 dose. Again, you'll go with, if at all needed, you'll go with infusion. Definitely, you are adding severe infection, metronidazole plus vancomycin, it will give added benefit. Different case, patient with patients with haplo bone marrow transplant for AML, they both found Clostridium difficile, both toxin and GDH positive. They started oral vancomycin 250 mg for Q630. 3 days later, patient developed ileus. What you will do? Already I explained. Please put it in comment. They started oral vancomycin, but still patient have developed severity. They developed ileus. Next, what you will do? Already I explained the answer. I told if severe infection is there, you will give high dose, 500 mg. Here, question wise, there is 125 mg systole only I told. Here they given 250 mg per systole. Ideally, we need to give 125 mg for mild infection. Severe infection, we need to give 500 mg. Plus, ileus suppose developed, you go with combination therapy plus metrogel. Another thing is intestinal, perrectal, better you give some infusion like the way. There is different tapering regimen also given for recurrence. This is called pulse regimen for vancomycin recurrence. Whether we will go with vancomycin or pidaxomycin. Here mentioned like way, recurrence is lower when pidaxomycin is used initially. That's why I am saying pidaxomycin is better than vancomycin for CDAR. Subsequent recurrence is there. Then that time also you need to consider both, but again you need to consider FMT. Any other drug will act on CDAR like the way rifaximin. Another one drug is tigecycline. The still data is that tigecycline gives some added benefit in CDAR. Another thing is rifaximin. We need to give more data. We need to know more data for rifaximin. That is FMT aspect. Let's will go. Another monoclonal antibody which was they practically would be impossible, but they give some added benefit. Besletoximab for prevention of recurrent CDAR. It's not for treatment. It's for prevention aspect. It is not going to treat the infection. It will improve the recurrence. So obviously, there is a benefit for besletoximab for preventing recurrence. Role of FMT fecal transplant. Let's see. The second or subsequent recurrence is there are pulmonary disease with concomitant ileus, refractory Clostridium difficile associated diarrhea. Even both GVHD or CDAD is there, whether you go with FMT. There is still question is there. We don't have clear-cut answer. How many times we need to administer for FMT? How long it will work? What about transmission of infection? Suppose we are giving blood transfusion, there is so much we are screening. Even organ transplant, we are so much screening for some test. That also need to consider. Okay, which route we need to give? Whether either we do lower GA tract or upper GA tract, either colonoscopy or NG tube, how to give? There is still we need to give. We need more data. Problem with FMT, patient acceptance is a big problem. Stool bank or capsule It all available in outside India. We don't have the tool banks or capture in our place. But if you want to do, you will go with normal patients with screening fecal simply into NG tube. It will be very simple procedure, but the patient acceptance is big problem in our place. Consider what are screening criteria for donor. Same like the way patients on any history, you need to ask for immunosuppressive therapy. Either even you need to ask for PPI last 3 months, family history, any viral marker, syphilis, we need to screen, cancer, anything there. That also we need to consider. And we also need to know the basic investigation. You need to rule out hepatitis or something, even intestinal parasitic infection, Cryptosporidium, Cyclospora, Isospora. For another thing is Clostridium difficile also we need to consider. The summary already I told. There will be we need to know whether infective or non-infective. First of all, toxin alone positive or GDS also positive. We need to know. Second thing is for recurrence, how to treat. That one also we need to give. Patient is mild or moderate or severe. When need to give monotherapy, when need to give combination therapy. That also we need to know. When the last thing is there is more fecal transplant, how to do. That aspect also still challenging, but we need to do. Because we are planning to conduct infectious disease conference in January 4th and 5th in Madurai. If you feel free, come and attend. Thank you. This is my number. If anything ID related activities, better call me. Thank you.
Thank you, Dr. Santanam, for simplifying the management and diagnosis of C. difficile. In India, I mean, Dr. Aaron, how is your experience with C. diff in Turkey there? Do you have many cases?
No, we have less patients, just from the other countries, and we use one oral vancomycin like yours for 4 times in a day. And I want to ask, how can we follow up this patient as laboratory? Can we check the difficile PCR test after the treatment?
Dr. Santanam, would you like to answer?
Same thing only I'm doing now. People transplant should be still questionable in our place, but many people they started doing. We need to patient acceptance only big problem in SOPS, right? The drug to diagnosis aspect will be still big challenging in our place. Here, obviously, there is India, there is so much misuse of antibiotics, the feeder would be there. But again, we need to confirm whether it's carrier or really infective. But the most, many cases we are seeing is infective. Again, the big problem is severity. Very severe, there will be even mortalities are going very high.
So, yes, actually, it is difficult for us to monitor. We will just look at the patient's response. If the patient is having severe C. diff, so the ileus will improve, his counts will get better, creat will get better. So otherwise, I don't think so. There's a lab investigation we can confirm because it tends to be positive even if the patient is responding to the treatment. So we will look at the clinical response, and that is how we got the response. I don't think so we can confirm it by lab eradication. Cultures are most often negligible. It is not positive, so you cannot follow through the cultures as well. So, and I think in India we do have a lot of antimicrobial resistance, but surprisingly we have less of C. diff, or we are not screening for C. diff enough. So both the ways, yes. So, any other questions? Please post in the chat box. We can take. Do you want to ask anything else, Dr. Aaron? Yeah.
No, thank you.
Yeah. So, thank you, Dr. Santanam. I think there are no questions as of now. So with that, I would like to thank you both for having making time and being a part of this webinar. So we'll move to the last topic of discussion today. That is, we are going to discuss about the actinomycosis. Let me share the screen. I hope my screen is visible. Yes. Is my screen visible? Anyone, can you please confirm? Okay, so thank you. So we'll just, it's going to be a discussion case series which I'll be discussing. So maybe we'll not discuss. I had various cases. I'll just see how many I can discuss. So without any further, let's start with the case one. So this is the case which we saw in during my residency. So we had a 21-year male with no comorbidities presenting to us with complaints of recurrent nodular lesions on the left side of the scalp with multiple episodes of pus discharge over past 2 years. Then he also had recurrent episodes of headache and vomiting for the past 6 months, with now having decreased vision in both the eyes and protrusion of the left eye. So let me make it clear with the pictures here. So this is how he presented to us. So he's having proptosis. You can see his left eye is like totally proptose, and there were multiple healed uh, sinus scarred lesions which were there all around his scalp. And on examination, his vitals were stable, multiple healed scars on the left temporal and occipital part of the scalp. Right eye, he had just light perception of the hand movements, and left eye, there was, if as you can see, there was conjunctival chemosis, periorbital edema, corneal scar, and only he had perception of light which was present. So coming to his occupation, he was a farmer by occupation, and all these lesions, like his protrusion of the eye, which started from 2 years back, and this was his current situation. So on the evaluation, we did CECT brain, which showed evidence of chronic osteomyelitis, that is calvarial osteomyelitis with mild hydrocephalus, with diffuse enhancing soft tissue swelling along the calvarium on the left side, with diffuse hyperosteosis of the calvarium and with the involvement of the left eye. So he also had some mild leptomeningeal enhancement and vasogenic edema. So for this, we sent all the usual routine investigation along with the skin biopsy. His viral markers were negative, chest X-ray normal. The skin biopsy showed multiple granules which are composed of filamentous organisms and showing chronic inflammation, and which was positive for PAS as well as GMS stain and negative for acid fast bacilli. So with, and this organism was gram positive, and so with all this, it was evident that this is a case of actinomycosis. So this patient we treated with initially IV ceftriaxone for around 3 weeks. Later we shifted him on capsule doxycycline, and at 8 months of follow up, he was symptomatically better. His chemosis, the protrusion of the left eye reduced. His from the light perception, he was able to now do the finger counting. So and the prognosis of the left eye was explained, and he was planned for the removal, but he didn't undergo any removal. So with that, we'll start with the actinomycosis. So, as we all know, actinomycosis is an indolent infection, and it is caused by the actinomyces and closely related species. And the characteristic feature of actinomycosis is abscess formation, induration, draining sinuses. So there is a triad. So any mass like lesion with discharging sinus and granules. So whenever you see these three things, you should think about your actinomycosis. And the characteristic other things which include is the chronicity, crossing of the tissue boundaries. So this is one such infection which does not respect tissue boundaries. That is, it can cross the tissue plane like the muscle, bone, and it will be presenting with mass like features. So that is why most often these are misdiagnosed as malignancy or any other granulomatous disease. And the sinus tract will develop and resolve and can recur along the course. Most of these patients will present late because they are usually slow chronic disease, and that's why they will have lot of relapsing infection. And it's not that all the infections caused by actinomyces will manifest with actinomycosis. I will be talking why do we consider so. So, how does this infection differ from other infection? One, as I mentioned, it does not respect the tissue plate. It's the hallmark of actinomycosis is the tendency to spread without regard to the anatomical barrier. And next is the formation of sulfur granules. So again, you should remember this sulfur granules is a misnomer. That has nothing to do with the production or whether the granules are composed of sulfur. No, it is basically because of the color of the granule. These are macroscopic grains and it is of hard inconsistency. These represent colonies of actinomyces species. And along inside this, there will be granulation tissue, uh, and which contains these beaded filamentous non-acid pass gram-positive bacilli radiating from the granule. So this is how this is a macroscopic demonstration of the actinomycotic sulfur granules. So when you keep a granule on the slide and in between two slides, and if you observe, this is how you are going to see, visualize the sulfur granule. So this is the first one is the GMS staining, which is showing the aggregates of the actinomyces. So these are the gram-positive club-shaped. These are the bacilli, which is arranged as a in a form of radiating pattern. Then this is the gram stain showing the gram-positive filamentous. If you can make out, these are very slender filamentous gram-positive bacilli. So coming to the etiology, as I mentioned, it is caused by the actinomyces, which is gram-positive branching bacteria, and it is non-sporing, non-acid fast. So this is an important feature because this is how you are going to differentiate from your nocardia, which is your acid modified acid fast bacilli. Again, that is also your gram-positive branching, but non-acid fast is your actinomyces, and your acid fast or the modified acid fast is your nocardia species. Then they have variable morphology and these are fastidious. So they are not obligate anaerobes, they are facultative anaerobes, but it requires enriched medium for its growth and it takes long time. So if you are suspecting actinomycosis, you need to inform your lab that you are suspecting and they will request enriched media, especially in a microaerophilic medium, and it will require longer duration of incubation. And some of the typical culture picture which shows this description is a molar tooth or the breadcrumb appearance. And there are various species, around 50 species are there, around which half of them will cause human disease. And why not all the infections or the all culture growth of actinomyces will not imply actinomycosis is because they are the form of normal, they've composed a normal flora. That is, it's a normal flora in the oral, in the intestine, as well as a female genital tract. So and most of these infections are polymicrobial. That means along with the actinomycosis, there are other aerobic and anaerobic bacteria. So there are can be as the common ones like your staph, strep, that is your part of oral flora. So why is this polymicrobial nature? Why is it important? As I mentioned, this actinomyces is microaerophilic. So that is why when the presence of other organisms, these aerobic organisms will make for the normal background for the actinomyces to easily grow. So the other organism will reduce the oxygen gradient or the oxygen saturation. So these organisms can then flourish. And one more implication of this polymicrobial nature is most often you may not get the growth of actinomycosis. One, because mostly these are very sensitive organisms, can be easily treated with just penicillin. So most of our patients are on broad spectrum antibiotic, so it may not grow. Second is because other things like staph, strep can easily grow, whereas these actinomyces will require special media and microaerophilic media, longer duration of incubation. So these may not be isolated that often. So how do they cause infection? Most often, these, as I mentioned, they are the part of the normal flora. So whenever there is a break in the normal mucosa, that is when it will enter inside and cause the infection. So if you talk about the common manifestation, that is cervicofacial actinomyces, so mostly they are in the oral flora. So whenever the patient is having tooth decay or like any periodontal pockets where there is a mucosal breach due to an ulcer or tooth extraction, along with this coupled with the microaerophilic environment due to the presence of other organisms, these actinomyces will grow, and this it is a slow process. So this will take around weeks to months, leading to the finally the clinical manifestation of the disease. And one important fact, they are the part of normal flora of humans, but they are not found in the environment. So you cannot dismiss it as a contaminant, but it could be a colonizer. Then it is worldwide distributed, and most common risk factors which is implicated is diabetes, malnutrition, immunosuppression, and anything which will breach this barrier. So any form of local tissue damage or inflammation like tissue trauma, dental procedures, osteonecrosis, poor oral hygiene, all these are the classical risk factors for your actinomyces. And as I mentioned, it is a chronic, slowly progressive infection, but doesn't mean there cannot be acute forms. There can be even acute forms, which is quite rare, but acute presentation, they can present as multiple abscesses. So a chronic disease, mostly they will present in form of indurated mass, which can slowly evolve to give abscesses, fistula, and draining sinuses. So as I mentioned, the infection process is ongoing, and it can spread to adjacent tissue. And as I mentioned before, it does not respect the anatomical barrier and it can cross easily. So later stages, there can be tissue fibrosis. So when you do the imaging, so what are you going to see? Mostly it is a presence of mass. And few of the cases, there can be abscesses, and as I mentioned, it can cross the tissue planes, and they appear, these masses are solid with low attenuation areas or cystic lesions in with a thick wall. And one classical feature, as I mentioned, they are mostly misdiagnosed as malignancy. One characteristic feature is they will directly pass through the tissue plane, and that's why there is no regional lymphadenopathy. Whereas malignancy is hematogenous, so there will be lymphadenopathy in malignancy, whereas in actinomycosis, there may not be regional lymphadenopathy. And coming to the sites of infection, as I mentioned, orocervicofacial is the most common site, which accounts for almost half the cases. Next is the abdominopelvic region. Next, the thoracopulmonary region. There can be cutaneous forms as well as CNS. CNS is very comparatively much rare. So, just a brief about cervicofacial actinomycosis. Most often these will present with this is the typical form of actinomycosis, which will present to you with a mass like lesion over the face, that is most commonly over the mandible, cheek, or the chin. So there can be multiple fistulas or the sinus tracts. The initial complaints may be, if they are not visible on the skin, it can be within the oral cavity, where the patient will present to you with pain and trismus. um, this is a typical image of the involvement of the left mandibular osteomyelitis with exposure of the bone, and these are the various sinus tract. So this patient who developed actinomycosis following the radiotherapy. Then this image is showing the mandibular lucencies. So these are all the various the X-ray where you can see the mandibular osteomyelitis that is due to the post dental extraction leading to actinomycosis. Next, the thoracopulmonary actinomycosis. So how does this occur? It is typically due to the aspiration. As I mentioned, actinomycosis is present in part of the normal oral flora. So this occurs when you are aspirating the bacteria, and especially the patients who are already having some dental disease or poor oral hygiene. And less commonly, it can also be due to the esophageal perforation or direct extension from the neck or the abdomen. Rarely, very rarely, there can be hematogenous spread as well. So again, most often this is not recognized, especially in a country like India. Any slow developing lung infection is first and foremost thought to be TB. So most of them will be already treated with ATT. Next, the symptoms also are not anything typical, so they can present with fever, weight loss, shortness of breath, reactive cough, that can be hemoptysis. So, in the X-rays, again, you can see there can be presence of empyema, or the patient can have abscess, lung abscess. So, all these patients, empyema, lung abscess, they are mostly thought to be your common infections like staph or any hospital like Klebsiella, etc. But actinomycosis is thought much lower down. So any patient who is having lung abscess, you in general, the patient looks very toxic, and the patient will have almost very acute presentation. Whereas these actinomycosis tend to be a little prolonged. There will be prolonged history, as well as the patient may not be as toxic. So, what is the complication of thoracopulmonary is this infection can spread. So, it can spread anteriorly, that as I mentioned, it can cross the barriers. So, it can cross the pleura and can appear in the chest wall as a sinus or fistula. Then it can spread to the anterior mediastinum, and so it can present as a mass or superior vena cava syndrome. It can spread to the posterior mediastinum, causing esophageal fistula, and it can further proceed backwards, and it can cause vertebral involvement as well. So this is the first image, is the chest presentation as a chest wall mass. Then this is the chest X-ray, which is showing the pulmonary infiltration, and along with the pleural effusion and the chest wall extension. And this patient, when once it was drained, so this is the chest wall extension of the involvement of the along with the involvement of the lungs. So, and this is the pus which is drained. Next, talking about the abdominopelvic actinomycosis, it often again due to the breach in the intestinal mucosal barrier, and mostly it is secondary to the abdominal surgery, trauma, neoplasm, or due to any cancer, etc. And most commonly, it is found in the appendix or the ileocecal region. They again will present with a chronic indolent symptoms like fever, fatigue, weight loss, abdominal pain. And again, most of the such a situation in India will be treated with for TB. So abdominal pelvic, like abdominal is more common than the pelvic. In pelvic, again, as I mentioned, it is a common flora of the female genital tract. So again, whenever there's a mucosal breach following surgery, most commonly it is associated with IUDs. So whenever copper teas, which so there is a breach in the, as I mentioned, it is a part of flow normal female genital tract, and whenever IUDs is inserted, there's a breach in the mucosa. So that's why they can present to you with pelvic pain, vaginal bleeding, and most of them these are misdiagnosed as neoplasm or any tubo-ovarian abscess. Next, uncommon form of abdominopelvic actinomycosis is the hepatic actinomycosis. Again, these are usually rare, and they are present with non-specific symptoms like fever, abdominal pain, weight loss, or malaise. Again, these patients will present to you as liver abscess. So, more actinomycosis is not thought I mean, no one will think about actinomycosis as a cause of liver abscess. Most often, these patients are all empirically treated with ceftriaxone and metronidazole. So that is why most and cultures, as we all know, may not always be positive. So this is an example of a patient with abdominal CT showing peritoneal effusion, and if you can see, this is the copper T. Along, so surrounding this copper T, there is a heterogeneous pelvic mass. So this was nothing turned out to be the actinomycosis, and this is imaging of a patient with multiple liver abscess, which is draining out as a sinus. So in this one, there was growth like the pus showed gram positive filamentous bacilli, which was your actinomycosis. Last, talking about the CNS actinomycosis, again, this is extremely rare, and like it accounts for less than 3 to 4% of the all cases of actinomycosis. Most often, it is due to the contagious spread. So the patient will be having cervicofacial infection. So it can, as I mentioned, it can cross the boundaries. So that's why it can involve your CNS. Rarely, it can also be through the hematogenous spread from other sites like lung or abdomen. And the risk factors, again, the dental procedure, head trauma, head surgery, etc. And again, they will present to you with non-specific symptoms, most often like there can be focal neurological deficit, headache, fever. Again, whenever you are seeing a patient with a chronic sort of a disease, you need to think about actinomycosis, and they will present to you with mass-like lesions anywhere else. So in the imaging, most common is said to be brain abscess, but again, I'll be showing the various cases which we have come across with CNS actinomycosis. We didn't find any case with any typical brain abscess. So other findings can be leptomeningeal enhancement, subdural empyema, ventriculitis, etc. So this is a CT scan showing the temporoparietal abscess with perilesional edema, and actinomycosis was found in the culture. And this is the MRI showing the left ear. So post earlobe infection acupuncture, there was this infection which again grew actinomycosis. So coming to the treatment of actinomycosis, as I mentioned before, actinomycosis is one of the like very sensitive organism which can be easily treated with penicillin. I'm sure most of the, like, especially in India, we don't have penicillin available in most of the places just because it is like considered not to be a treatment anymore. For like even for syphilis, we struggle to get the penicillin for treatment. So again, as I mentioned, it can be treated with a drug like penicillin, but most often these patients are treated with higher agents like your ceftriaxone. Even some patients even are treated with most common misdiagnosis even after confirming actinomycosis is confusing it with actinomycetes. So where they usually use aminoglycosides also as a treatment, but it is actinomycosis is not to be confused with actinomycetes. And the important thing is the treatment of choice is your penicillins, like your if you don't have penicillin, you can use amoxicillin or doxycycline, minocycline, and clindamycin. They have extensive successful clinical experience. Other things which you can use is your ceftriaxone. Um, Definitely, though imipenem piptaz can be used, I would say please avoid it when you can treat with a lower agent. Then there are certain agents which should be avoided in actinomycosis. First is foremost is metronidazole. So not all of your anaerobic infections are treated with metronidazole. So this is also one of the examples. Then obviously avoid aminoglycosides. Your penicillin is resistant penicillins like nafcillin, oxacillin, ceftazidime, cephalexin, fluoroquinolones, and antifungal drugs. So though they are filamentous gram-positive bacteria. They are not fungi, so need not be treated with your antifungal agents. and not to be treated with metronidazole and aminoglycoside. So usually antibiotic treatment, as I mentioned, it is a polymicrobial infection, so they need to be treated with covered for the concomitant companion organisms. Again, we won't have any RCTs which can tell one treatment is superior, because, as I mentioned, these are one of the rarer infection. In general, we usually give IV treatment for up to 2 to 6 weeks, followed by oral therapy for a total duration of 6 to 12 months. Again, as I mentioned, the duration is also a matter of debate. You can still use shorter duration if it's a less extensive disease, and you can surgically drain the any surgically remove the mass or surgically drain the sinuses. And often the treatment duration is monitored by the response to CT or the MRI. So next, I would like to discuss few CH. So that first case which I discussed was one of the cases which we had. So we had other three cases. So we had a total of 4 cases of CNS actinomycosis, which we reported. Again, if you see, most often the risk factor which we found was dental caries, and most often these patients will present with chronic history of some headache, some weakness, and multiple discharging sinuses, etc. And imaging, as I mentioned, we didn't have any typical uh, abscess. For the case 1, as I had showed, there was a mass-like lesion. Case 2, we had the patient who is having diffuse scalp and calvaria thickening with enhancement and some peripheral enhancing collection. Case 3, the case we just had a patient with some mass effect and not no typical leptomeningeal enhancement or any abscess. So most of these all patients, we had a concomitant organism which was growing, and most of these were diagnosed based on the HPE. So HPE is quite important when you're planning, when you're diagnosing actinomycosis, because, as I mentioned, culture, it may not grow in most of the situation, because most of these patients will already be on the antibiotics, or because it is difficult to grow, it requires special media. So HP is the like we can say even the gold standard for the diagnosis, where you will see the typical granulomatous inflammation with filamentous bacteria, which is PAS and GMS positive. And the median duration of treatment which we used was almost 6 months. Some patients we have treated for long, up to an year as well. So most often during the parenteral therapy, we have used the ceftriaxone for up to for almost 4 weeks, followed by we have given the follow up with added amoxicillin. The first case we treated with doxycycline, then some of these cases which we have treated amoxicillin. The important thing to note here is the amoxicillin dosage for actinomycosis is quite high. It is 2 gram BD we'll have to give. So usual amoxicillin tablet which you get is around only 500 mg. So you need to educate the patient so that they take the sufficient dose. Like they will need to take around 4 tablets. So when you look at the level and we review the cases of CNS actinomycosis, so this was almost like the first review in the very old review of published in 1987, which reviewed 70 cases of CNS actinomycosis, where they found that typical lesions of brain abscess was found in almost 1/3, I mean 2/3 of the patient. And this was mostly hematogenous spread, and they presented as space occupying lesion. Most of them gave the duration of therapy, median duration was 5 months, and the overall mortality is quite less, with around 28%. But important thing to note here is most of these patients will have some neurological sequelae, and poor prognosis was seen in whenever the patient had longer duration of onset and later presentation. And surgical drainage is equally important. And most of these, whenever some of these cases were also treated with combination therapy. So I'll be just skipping through this in order to save some time. And this is the most recent review of the CNS actinomycosis, it was published in 2018. They had reported this was a review of around 20 cases. Again, here, if you can see, they had more or less around chronic onset, with most of these patients had presence of any some abscess, and but the duration of treatment they have mentioned is for a little shorter duration was used for, like, some of these patients were treated as less as 2 months. And these are the typical some of the images which showing the frontal hypodense rounded with hyperdense rim, and they have followed for quite long. And if you can see, most of these had companion organism like streptococcus, mrsa, cons, streptococcus species. uh, One of these cases also had presented as proptosis. So next, talking about the next type of presentation. So we had a 37-year-old man presenting with history of 2 months history of intermittent fever and upper left abdominal pain. Uh, the patient had history of low-grade fever, and on examination there was abdominal tenderness. Oral cavity there was few caries. Labs, it showed increased neutrophilia with other things normal. The patient was HbsAg positive, along with we sent for other screening. It was normal. USG showing heterogeneous abscess. And so there was if you can see, there was well defined abscess in the spleen, whereas in the liver there was no lesions. So empirically, the patient was put on ceftriaxone plus metronidazole, but the patient had fever spikes, persistent fever spikes. So the patient underwent expiratory laparotomy, which revealed multiple liver nodules and a splenic abscess. The patient eventually underwent a splenectomy. So if you can see, there are multiple surface nodularity and multiple pus-filled nodules, if you can see here. So this culture, finally, the H&E stain showed this typical chronic inflammation with which was showing sulfur granules with filamentous gram-positive acid fast negative vessel, which was nothing but your actinomycosis. The patient was then changed to high-dose penicillin G for 1 month. Later, as expected, the bacteria failed to grow in both these cultures. Um, so patient was shifted to oral penicillin for the next 3 months. After 4 months of therapy, when the abdominal MRI showed total absence of hepatic lesion, the patient was stopped. The treatment was stopped. So talking about hepatosplenic actinomycosis, this is a systematic review of the various case reports. So there is no obviously any formal study. So this is a systematic review of the case reports of hepatic actinomycosis between 2000 and 2020. There were around 22 cases, in which when they evaluated the common complications, the patients or the risk factors, most of these patients had underwent some sort of abdominal surgery or had presence of foreign body. The clinical manifestation, as mentioned before, the patient, most of these patients with present with some chronic abdominal pains, fever, weight loss, night sweat, and most common laboratory finding was leukocytosis, elevated ALP, and then elevated CRP, inflammatory markers like ESR, CRP. The most common diagnosis was malignancy. followed by pyogenic liver abscess. So that is why it is important to do any patient with liver abscess. It is important to do the cultures as well as send a sample for even HP, because as I mentioned, most of these will not grow in the culture. So most of these, after the diagnosis, was treated with penicillin followed by amoxicillin. If you can see, so this diagram illustrates the importance of the method. So if you can see, most like almost around two-thirds were diagnosed based on the HND. Culture was positive only in around 10%, 10 to 12% of the cases. So concluding, hepatosplenic actinomycosis will be misdiagnosed or as fungal infection or malignancy, and in India definitely TB. We need to confirm the diagnosis and send for HP. uh, so next, this was an important report where they had looked at short-term treatment for actinomycosis. So why this is important? Because most of the like as we mentioned, there cannot be any formal guidelines for the treatment. So most of the treatment duration is quite prolonged, and it is based on the clinical and radiological responses. Here they have looked at the reviewed the various treatment durations. So traditional course is around 6 months to 1 year, and it is not necessary to give that entire duration for all the patients. So for some forms of actinomycosis, like especially cervicofacial, you can give the for duration, for you can reduce the duration or you can give shorter duration of therapy, and maybe longer duration of therapy may be required in certain diseases like your thoracic or abdominal, where you may not be able to do the necessary debulking. So in C, and last thing is CNS actinomycosis, as I mentioned, is again quite rare. So I think they will benefit from a longer duration of therapy. You need to do repeated radiological imaging to look at the response to the therapy and guide your duration based on the imaging. So talking about, so concluding, rare infections are actually not so rare. We don't look for it. This can actinomycosis can mimic your various infections, including a bacterial, fungal, tuberculosis, malignancy. Most often these are misdiagnosed as malignancy, and in India definitely misdiagnosed as TB as well. Antibiotic therapy, it cannot be standardized. You cannot tell this patient should be treated on this and for this duration. It should be individualized based on the patient's clinical and radiological response. Uh, so with that, we'll end it. Thank you. I can take any questions if there are any. Okay. So, Dr. Erin, do you have any, have you seen or any experience with actinomycosis?
Yeah, I have seen once, and uh, we have um, as differential diagnosed TB. We have suspicion about TB, and when we took a biopsy and we saw the culture and traits like yours. And I want to ask you a question. In your patient, did he has diabetes mellitus? And
No.
no, okay. Did you study Graham's training before biopsy?
Okay, so no, gram staining was done as a part of like whenever this most of these have mass like lesion. So when we biopsy or when we send for HP, gram stain and HLE, they are done as a routine. So yes.
Okay.
So Dr. Santanam, you want to add anything? So Dr. Santanam, we both together we were there when we looked at these cases of actinomycosis. So Dr. Santanam, would you like to add anything?
No, mom. Just I have still figured out. There many people adding Metrogyl. What is your opinion?
Okay, Metrogyl again. As I mentioned, it is not a treatment for your actinomycosis, but again, other anaerobic infections cannot be ruled out. In co-infection can also be there. So companion organism. So yes, especially for your, I think your orocervical actinomycosis, there can be some benefit. And most of them, as I have mentioned, you will not have culture positivity. So whenever the patient is having brain abscess, so it's natural that the patient will be on metrogel for abscesses. Yes.
In my
Another question,
estimation,
yes,
sorry.
yes, please.
Okay. In my estimation, maybe we should cover anaerobic pathogens, and maybe we can add anaerobic treatment like metronidazole because of the oral flora, and you talk about the co-infection, not just actinomyces.
Yes. Yes, Santanam, Dr. Santanam, you are saying something?
Yeah, I have another doubt. What about penicillin allergy patient? What drug you will give?
So penicillin allergy, doxycycline is an excellent drug. So you can give doxycycline. And most often for penicillin allergic, what we give is fluoroquinolones. Again, fluoroquinolones is of no use in actinomycosis. So doxy, we have used doxy in our patients. So yes, we can use easily doxycycline. Um, Cotrem also cannot be given. So oral option, yes, doxy is an excellent option. And I think one more thing is whether you should just confirm whether actually the patient is having any penicillin allergy, because most often patients are misdiagnosed as having being allergic to the penicillin.
Yes.
Hmm. Let me check in the chat. I think there are no questions. Anyone would like to ask anything further to any of the speakers, please feel free to unmute yourself and ask, or please leave it in the comments. Okay, I think there are no further questions. So I think with that, we can come to the end of this webinar. So yes, the recording of this will be available on my YouTube channel. If anyone would like to, if you have missed any part of the talk, you can always access through that. So I'll be announcing the next webinar soon. So see you all next month. And again, I would like to extend my thanks to Dr. Erin and Dr. Santanam for making time and being a part of this initiative. Thank you once again.
You're welcome. Thank you.